So it's my great pleasure to introduce Dr. Lisa Littman. Dr. Littman is a physician and a researcher who's currently the president of the Institute for Comprehensive Gender Dysphoria Research. And she's previously held academic positions, including at Brown University School of Public Health. Her 2018 paper on rapid onset gender dysphoria described the emergent phenomenon of teenagers identifying as transgender without childhood dysphoria. And I think it's safe to say that it caused quite a stir internationally. And more recently, she's published one of the first surveys completed with people who've detransitioned from a transgender identity, which is what we're going to be hearing about today. So with that, I'll pass over to Lisa. If you can just let me know when you need me to change the slides as well, Lisa.
Thank you for the introduction, and thank you for inviting me to your event. Next slide, please. I'll be talking about detransition today. And what is detransition? At its most basic definition, detransition is the act of stopping or reversing a gender transition. It is one of several possible outcomes for transition. And detransition is not the same thing as regret, although there is likely substantial overlap. So there are individuals who detransition but do not regret their transitions. And there are people who regret their transitions but do not detransition. And interest has been raised recently about detransition, and there's still some variations in how it's used. Some individuals will use detransition only for individuals who have medically or surgically transitioned, and other people use the term for people who socially transition and then detransition or desist from there. Next slide, please. So in an ideal world, we would be viewing detransition as an important outcome of transition and use that information to inform the process of evaluation, counseling, informed consent, and provision of care. However, it is quite controversial at this point. I know that this is a multidiscipline group, so I'm going to take a few minutes to explain this slide a little more because there's a lot going on here. So on the left side of the slide, I start with gender dysphoria, and there are different types of gender dysphoria. There is early onset gender dysphoria, where individuals become symptomatic as young children. There is late onset gender dysphoria for natal males, and both of these types of gender dysphoria have been understood and researched for decades and decades and decades. Prior to 2012, there was little, if any, research or visibility of females, natal females with late onset gender dysphoria. And this presentation is relatively new. It's important to note that the past decade, 10 to 15 years, there have been remarkable shifts in patients presenting for care for gender dysphoria. And previously, the typical patient was either a middle-aged natal male or the childhood presentation predominantly male. And over a relatively short period of time, this has shifted in that there has been a sharp increase in teenagers, most notable for female teenagers. So where the typical patient at a gender clinic used to be an adult male or a child who is male, the typical patient is now a teenage female. And so this is not well understood. It's possible that some of this could be due to decreased stigma or differences in stigma, but there's still, it doesn't explain the whole picture. Why has the sex ratio flipped for teenage females, but not older females? Anyway, it's important to understand this and to eventually figure out what's going on and to ask research questions. So anyway, so once a person has gender dysphoria, that gender dysphoria may either resolve on its own, which is called desistance, or it may persist, which means continuing on. And you'll see the little curly Q arrows, and that means that these may not be the final endpoints. Individuals who persist may later desist, and individuals who desist may eventually become gender dysphoric again. But it's important to understand that the research shows that the majority of young people, children who are gender dysphoric, will most likely grow up to be not transgender, will most likely grow up to be lesbian, gay, or bisexual adults. So once we get to gender dysphoria, someone may choose not to transition, or they may choose to transition. And a person who transitions may be satisfied with their transition and may stay transitioned. Or they may be satisfied with their transition, but detransition due to situations that might be considered externally motivated. Things like discrimination, pressure from family, or medical complications that, so that's another scenario. For individuals who are dissatisfied with their transition, they might stay transitioned, or they might detransition for a variety of reasons. And I have those little arrows there between satisfied and dissatisfied, because I've heard anecdotally that individuals who detransition will often feel better initially and then become dissatisfied, or then will start to identify issues or problems. Next slide, please. So a typology for detransition has been proposed to better organize really the thought process around detransition. And this is based on the reason why a person detransitions. Core detransition is defined as detransitioning for reasons fundamentally related to no longer identifying as transgender. So on the left, I have some points about that. Some individuals may conclude that the underlying causes of their distress were due to other issues that were not related to being transgender, or whether, they may doubt that they, or may feel that they were not transgender. So another possibility is solving the psychological or emotional issues that contributed to their gender dysphoria. Temporary gender dysphoria in individuals who are lesbian, gay, or bisexual is not uncommon. So core detransition could be defined as somebody who begins to accept their sexual orientation as same-sex attracted, and then no longer identifies as trans, or resolution of gender dysphoria over time. So we often discuss gender dysphoria as if it were permanent and always present, or but there are many cases where individuals will experience gender dysphoria, and that gender dysphoria resolves. And non-core detransition is defined as detransitioning for reasons that are not related to change in identification. So for individuals who are still trans identified, as I mentioned, discrimination, pressure from other people, medical complications, or the emergence of a non-binary identification. So on the left, the core detransition really is related to a shift in a person's self-conceptualization. Next slide, please. So how often does detransition occur? What is the prevalence of detransition? How many people who transition are likely to detransition? And there are a lot of unknowns here. The first thing you want to ask is, what were the conditions of the transition? Because your detransition rates are going to be different based on those situations. So, in cases, or in countries or parts of countries where the approach to transition is thorough evaluation, having eligibility criteria in which those individuals most likely to benefit will receive transition, and those believed likely to be harmed do not. You may have one detransition rate, or in another scenario, such as many places in the United States have adopted an informed consent approach in which there is no mental health evaluation. An individual can, 18 years or older, go to a clinic and without any mental health evaluation, receive cross-sex hormones at the same or the next visit. And there are places to get, to cross-sex hormones online through video conference interviews. So we would expect that the detransition rate might be different in those scenarios. There are a lot of challenges to getting an accurate understanding of detransition rates. One is there is a lot of stigma. Many individuals who detransition don't return to the clinics. So for detransition rates that are derived from clinic records, they're going to be significantly underreported. Another challenge is that many individuals who detransition are no longer trans-identified and are no longer part of political communities that are promoting transition. So again, if the research is based on surveying communities of politically active transgender individuals, many detransitioners will be missed. Another thing that would affect detransition rates is how detransition is defined. Is it a very high bar in which an individual needs to legally change their identifications on government documents? Is it a bar in which they need to return to the clinic, or is it something else? Another issue is how long. Are we talking about detransition after 1 year, 5 years, or 10 years, or longer? Many of the studies find that the average time to regret is often 8 to 10 years. So it's possible that, or it's likely that research that follows for 1 year or 2 years detransition rate, it's going to be very, very much underreported. And to show sort of the difference in ranges, some of the detransition rates in studies are less than 1%, 2%, and then some of the more recent ones that are done in the UK in the past, actually 2021 and 2022, that have been audits, have found higher detransition rates of 6.9% or and 9.8%. So next slide, please. So with that as background, I'll move on to my study in which I surveyed 100 individuals who had detransitioned. Next slide, please. So the purpose of this study was to describe a population of individuals who detransitioned. For the purpose of this research, I defined detransition as a process where an individual who obtained medical or surgical transition then, for the purpose of detransitioning, discontinued medication or had surgery to reverse the changes from transition. Next slide. So this was a descriptive exploratory study employing an online anonymous survey. For the research, I collaborated with 2 individuals who had transitioned and detransitioned themselves. And this was enormously helpful in terms of the creation of the survey to create questions that were clear and were relevant to a range of detransition experiences. These individuals also helped with the recruitment process. This study was unlike many studies in this field in that we reached out to communities with different perspectives about transition and detransition. So on one hand, a very pro-transition communities, we reached out to WPATH, which is the World Professional Association for Transgender Health, and the American Psychological Association, their listservs to try and reach participants. And we also reached out to communities that may have less of a strongly pro-transition perspective, such as detransition forums. And to be eligible for the survey was, as I mentioned, having taken medications or had surgery, and then reversing by stopping medication or having surgery. So next slide, please. We were able to we received 100 surveys that met the eligibility requirements. And our participants were between the ages of 18 and more than 60 years of age. So it was a really broad range. And as you can imagine, individuals who transitioned and detransitioned 2 years ago, 5 years ago, had very different experiences than those who transitioned and transitioned, let's say 30 years ago. So my population was predominantly natal female. predominantly from the US, but also from the UK and Canada and Australia, predominantly white, strongly supported lesbian and gay rights to legal marriage, and first heard about the survey in a couple of different places, including other social media. Next slide, please. So the population there were significant differences between the natal females in the study population and the natal males. So most of the data on this slide were items that were statistically significant. Those with asterisks were not statistically significant, but I thought it was important to describe them. So the females were younger at the time of the survey than the males. So if you look at the top of the slide, the females were a little less than 26 years of age. The males were almost 37 years of age. So that's like that's a big difference. So the natal females were younger when they sought care for transition. They were younger when they detransitioned, and they remained transitioned for a shorter duration of time before detransitioning. So roughly, they were 20 years of age when they sought care for transition, almost 24 when they decided to detransition, and remained transitioned for about 3 years. They also transitioned much more recently, with an mean average year of 2011 than the males. And that may, and those differences might reflect different eligibility criteria, different cultures for that. So in contrast, the males were 26 when they sought transition, almost 33 when they decided to detransition, and remained transitioned for roughly 5 years. The natal females were more likely to report having had a trauma less than 1 year before the start of their gender dysphoria, and were more likely to report that they felt pressured to transition. The sex differences for feeling pressure to detransition were not significant, but it's important to talk about both of them. And in an ideal world, nobody would feel pressured to transition, and nobody would feel pressured to detransition. And so there were a number of people, 37% for transitioning, 23% for detransitioning. And those are just important that we understand these pressures and try to understand and maybe help prevent people being pressured in either direction. So in terms of early and late onset, the natal females more of them had late onset, and more of the natal males had early onset gender dysphoria. Next slide, please. So the process, because I defined the eligibility criteria for being medical, it's not surprising that there were high numbers of people medically transitioning, but 96% transitioned by starting cross-sex hormones, and about a third of the natal females had mastectomy. Much smaller numbers had genital surgery. For detransition, the most common action to detransition was stopping cross-sex hormones. 14% started hormones consistent with their natal sex, and 6% had surgery to reverse the changes. Next slide. So at the time of transition, so these boxes are how individuals identified. And you can see the numbers there, but because the number of my survey, the number of participants is 100, it's seamless to go from like N to percent. So 80% of the, so let's say it this way, 98% of the individuals in the study identified as either transgender or non-binary or both at the time of their transition. And then at the time of the survey after detransition, 61% had returned to identifying as their birth sex, 14% were identifying as non-binary, and 8% were identifying as transgender. And then you can see the overlap in the overlap of the circles. Next slide. There were a lot of different reasons for transitioning. I think it would be really interesting to ask this type of a survey question to individuals who remain transitioned to see whether they are different. But there's probably significant, my guess is that there would be significant overlap. Individuals who transition actually all of them had transitioned. But the reasons for transitioning were that they wanted to be perceived as the target gender. They thought transition was the only option to feel better. Their body felt wrong the way it was. And they thought that transitioning would eliminate or lessen their gender dysphoria. Next slide, please. So there were many different reasons for detransition. And the most common reason is that individuals reported that their personal definition of male and female changed, and they became comfortable identifying as their birth sex. Some had concerns about medical conditions. Some had experienced that their mental health either did not improve or worsen with transition. Some were dissatisfied with the physical changes, and some discovered that their gender dysphoria was caused by something specific, such as trauma or a mental health condition. And then smaller numbers experienced discrimination, financial barriers. Next slide, please. So in evaluating the data, I analyzed it or categorized into several transition and detransition narratives. And this was based on answers to some of the open-ended questions as well as some of the closed, multiple choice questions. So 58% of the individuals expressed a narrative that their gender dysphoria was caused by a trauma or a mental health condition. Clinically, I think this has great meaning in terms of the evaluation process and whether, and how thoroughly clinicians are ruling out underlying conditions. 29% had experiences consistent with the discrimination, external pressures narrative. 23% had what I called the internalized homophobia, difficulty accepting themselves as lesbian, gay, or bisexual narrative. And so I'll give some explanation. My next slide is going to have sort of quotes from each of these. But basically what this means is that individuals felt that in retrospect that their gender dysphoria and their desire to transition stemmed from having difficulty accepting themselves as lesbian, gay, or bisexual. And that when they began to accept themselves as lesbian, gay, or bisexual is what was related to their detransition. Another narrative was social influence. And this was where individuals not only felt pressure to transition, but identified in the open text that the source of their the pressure was a social cause, such as being pressured from their friends, being pressured from their doctors, being pressured from their partners, or being pressured from internet communities and forums. There was a non-binary narrative where individuals either moved to a non-binary identification after transitioning, or individuals that started the process of transitioning as non-binary and then stopped because the transition had given them the desired effects that they wanted. 7% of the natal females expressed a misogyny narrative, and 3 individuals retransitioned. So next slide, please. So to better describe what these narratives were, these are quotes from individuals that were categorized into each of these. So for trauma mental health one is I was deeply uncomfortable with my secondary sex characteristics, which I now understand was a result of childhood trauma and associating my sex characteristics with those events. For discrimination, I felt much happier with myself, but I couldn't go anywhere without being afraid. The internalized homophobia narrative, transitioning to male would mean my attraction to girls would be normal. Social influence, everyone says that if you feel like a different gender, then you just are that gender and you should transition. For the non-binary narrative, then I realized I was not male but genderqueer. Misogyny, finally realizing that there's nothing wrong or disgusting or weak about being female. And then retransition was I am now transitioning for a second time. Next slide. I was really interested in what individuals, what their experiences were interacting with mental health professionals and doctors. So more than half of them felt that the evaluation that they received from a doctor or mental health professional was not adequate before they transitioned. More than half reported that the clinicians did not evaluate whether their desire to transition was due to trauma or a mental health condition. Nearly half of them believed that the counseling they received was overly positive about the benefits of transition. And less than a quarter of the participants had informed the doctors or clinics that they had detransitioned. And this has significance in terms of doing estimates from clinic populations, knowing that very few return, but also the clinicians who are facilitating transition are more likely to see patients that are happy with that care, and that may influence their perspective on these treatments. So next slide. The participants were asked a variety of questions about their experiences and how they viewed them. Regret was common, and about half of the participants reported strong or very strong regret. But speaking to the diversity of these experiences, this was not universal. Some people did not have regret. Most participants were dissatisfied with their decision to transition, and most respondents were satisfied with their decision to detransition. Most indicated that if they knew then what they know now, they would have not chosen to transition. So next slide. So the conclusions of this research is that detransition experiences are diverse. Some people are satisfied with their transitions and only detransition because of discrimination, external pressures. Some people detransition because they realized that their gender dysphoria and drive to transition were due to other conditions, such as a mental health condition, trauma, internalized homophobia. So many of these, another key point in terms of conclusions is that many participants reported that the evaluations they received prior to transition was inadequate, and only 24% informed clinicians that they had detransitioned. So like any study, this study has limitations. It's a convenient sample with targeted recruitment, which always introduces selection bias. Although I reached out to a broader range of communities, it's important to go even broader for future studies. There was anonymous data collection, and it's a cross-sectional design, which means that you cannot determine cause and effect. So those are the caveats. And going forward, more research is needed to identify how best to support the long-term health and well-being of individuals who detransition, to really get a handle on what detransition rates are, with the recognition that it's going to be different based on the approaches. So what are the detransition rates for each approach should be researched, and is a really compelling question. We should be exploring current evaluation and counseling processes, and we should obtain data about the trajectories and outcomes for youth with late onset gender dysphoria. There are no long-term or follow-up studies for teenagers with late onset gender dysphoria. The research that is related to cross-sex hormones, puberty blockers, and surgeries for adolescents are based on those with severe early onset gender dysphoria. So, another thing in terms of getting more information is that because the cohort has changed so substantially in the past 15 years, we really don't know much about this new cohort. And so we need to understand better what their persistence rates are, what their desistance rates are, whether they are helped by the current interventions or whether they're harmed by them. So next slide, please. And there are my references. So thank you very much. And I look forward to your questions.
Thank you, Lisa. So I'll stop sharing. Now that was excellent. It was so clear.
Thank you.
So does anyone have a question? If you just want to raise your hand. So Jackie.
Hello, good afternoon, everyone. And Lisa, thank you. Thank you so much for that. It was really interesting and clear. But I think I need to ask you to help me understand something I think you said, but I may have misheard. So I'm a senior lecturer at the Open University, and I work in the Faculty of Health, Wellbeing and Education. And I think, Lisa, you said that there were health-related concerns exhibited by some participants related to remaining transitioned or detransitioning. So maybe I didn't hear clearly. Please help me, Lisa.
Yeah, so some of the individuals in the study detransitioned due to concern about complications. So not necessarily having complications, but being concerned about having complications. But some of them did experience complications, and I don't have the number for that.
Okay, thank you. So I think I did hear correctly. That really helps me. Thank you.
No, you're welcome.
Thanks, Jackie. And we have a question from the chat as well. What do you think are the major health concerns in the detransition population, and are they different for natal males and females?
The health concerns, I do think they're different. Just thinking back to what some of the open-ended responses were, there were some of the natal females who were concerned about future fertility. So that is a medical concern. I believe males may have had some concerns about things along the lines of heart attack, stroke, of that nature. But yeah, I do think getting a handle on what the actual complication rates are for these, and we are getting some research about that, but also what the concerns are.
Yeah. Great. Jess?
Oh, thank you, Lisa. I'm really interested to know whether you've been able to elicit, even at a very sort of limited stage of your research, whether it's possible to get a sense of what are the reasons or factors why young people start thinking about detransitioning. What new information, what changes in their mind, how do they get to that point of being able to think differently?
Yeah, so not this study, but the next study that I did that's currently under review, we asked a series of questions in which we asked individuals which of the following factors, or actually we had them rate factors on how important they were to becoming gender dysphoric and trans-identified. And we also had a list of factors that we asked individuals how important they were in terms of their desisting or detransitioning. So stay tuned. But we did look into that, and I don't have the data right at my fingertips, but it was very interesting. But I think it's a great question, is understanding why, what changes, what are the factors.
Thank you. Well, I have some questions as well. So one of the things that really struck me in your presentation is the diversity, both in the pathways in and the pathways out, and also the diversity within detransition itself. you have these different there's different pathways. So some people it's a kind of wholesale change, other people it's it's kind of they don't change their core identity. And it sort of strikes me that that's very different from the kind of the narrative that's out there, which is very simplistic, really, both in terms of transition and sometimes also in terms of detransition. And I just wondered what you thought about how maybe your research can help to break down some of those simple narratives.
Yeah, I think you're exactly right. I think a big problem with the way we discuss it and the common narrative is that it's very much oversimplified. And so this idea of either you are trans or you're not, and if you are, you need to transition. And if you transition, you are only people who transition are satisfied, period. And if they detransition, it's only because of external pressures. And so, there's one, it's very oversimplified, but two, I think it's serving a purpose because there are two different factions, probably more than two. Sorry if I'm oversimplifying, but the two different factions. And one is a sort of a belief system in an innate gender identity that's like a soul that can be within, it's in somebody, it could be within somebody's body and it can not match with their biological sex. And that belief system really contributes to this idea of transition as fast as possible without evaluation. And we see this a lot in the United States. And so here's what I think has gone wrong in the debate, is that we should be putting the health and well-being of all individuals who experience gender dysphoria as the top priority. And that means that there may be different approaches that are best for each person, for different people, but we need to remain open to the pros and cons of each approach. In contrast, I do think that there is a faction of individuals who have, instead of prioritizing the health and well-being of all people experiencing gender dysphoria, they've attached themselves to fast-tracking transition and then viewing the world in terms of, if you support fast-tracking transition, you support trans people, and if you don't, you're anti. And so in that world, so it would justify fast-tracking transition if it were true that nobody desisted, and if it were true that everybody was satisfied with transition. And so I think some of the animosity towards detransitioners who do not follow the script comes from this really a strong desire to support the fast tracking of transition. And again, I think that's really not respecting all people experiencing gender dysphoria. It's only respecting people who are helped by transition. And that's a very different way to look at things. So yeah, so back to your other question, how can my research and other research that kind of takes this broader developmental approach to gender dysphoria, that there are many different things that can cause someone to feel gender dysphoric. And I think just the more research there is that speaks in this, because I think once you have context, you can't unsee it, So I think just more discussing this context, because people who desist exist. People who are harmed by transition exist. People who are helped by transition exist. And so the more we talk about the big picture, and the more that individuals who have all these experiences are speaking out and becoming more visible, I think that also helps, because it's harder to deny the existence of people who are right in front of you.
Absolutely. Do we have any more questions from the because I have lots of questions, so no problem. The other thing I was wondering about was
there's lots of questions in the chat.
Okay. Oh, yes, I foresee one. Could you talk more about the questions and answers around social contagion, please?
Sure.
Yeah.
Yes, that was probably one of the most contentious of my findings in the first paper on this topic. First of all, I feel that the pattern that is now being observed for individuals becoming gender dysphoric and trans-identified, where it occurs in clusters of friend groups, of pre-existing friend groups. This is the stories that we're hearing is not an individual who's struggling and then seeks out a different friend group of like-minded people. It's certainly many stories of these pre-existing friend groups that were brought together for completely random and different reasons. You know, it would have been remiss to not notice something that used to be incredibly rare that is now occurring in groups of 3, 5, 6, 10. So I think that's something that definitely raises a question about, is there social contagion? The types of activities I looked at that could be related to social contagion were also the dynamics in the friendship groups. It wasn't just that the friendship groups were interested in this topic, but they were actively mocking anybody who was not trans-identified, including, you know, siblings, parents, other friends, strangers, as well as having an increased popularity when a person announced that they were gender dysphoric or trans-identified. And these types of behaviors were identified in the first study with the parent report study, which, you know, as we know, has limitations about parents, whether or not they know exactly what's going on in their child's lives. But there was significant detail that parents provided about how these saw these behaviors. But it was also echoed in the detransitioners, pointing out that in their own friend groups, they were, you know, their friend groups were mocking people who were not trans-identified, and that their popularity increased with their plans to transition. So we don't have, you know, this is not hard and fast, it must be. We don't have evidence that says, yes, it is, or no, it isn't. It's just that these things are suggestive and deserve further research.
Yes, thank you. A question from John in the chat as well. A crude folk view might be that LGB acceptance is higher than T acceptance. How does this fit with the view that in 23% of cases, trans ID was a way of coping with LGB identity?
I think you're going to have different pecking orders in different scenarios. For example, in the Middle East, you know, transition is in some countries is readily available, but being lesbian, gay, or bisexual is punishable by death. Okay, so that's one extreme. What I heard in this, you know, so currently, let's say in the US, you know, there are going to be certain circles where it is much more desirable to be trans than LGB, and circles where it's more desirable to be LGB than trans. So, for example, if we think about religiously conservative communities where their young son is, you know, putting on dresses and belting show tunes and things of that nature, you know, in that setting, parents would be very resistant to have a gay, you know, a child who is gay, but it is much more comfortable for them to have a trans, you know, identified, a trans child or a trans, you know, adult. So that's in one scenario. You know, but even in very progressive circles, what I've heard from individuals who are detransitioners are that, you know, the pecking order of, you know, it's very, in some circles, it's very cool to be trans and very uncool to be a lesbian. You know, I think lesbians, and especially masculine presenting lesbians, are really getting a lot of discouragement, a lot of hostility. You know, I'm hearing these echoes of, you know, I didn't want to be a lesbian. And so there, I only gave one quote in this presentation, and there are several quotes in the paper, and I had to cut several more out because the paper was quite long. But there were a lot of people saying specifically, I didn't want to be a gay man. I didn't want to be, you know, like my same-sex attraction would be normal if I were a trans man attracted to girls, or it was less shameful to be a trans guy than a lesbian. So again, we're going to have pockets of different priorities, but it's important to be aware of both, because, you know, in those areas that are, you know, pro-trans in terms of, you know, so much stigma against being lesbian, gay, or bisexual, you know, that's bad, you know. And same thing, if there's so much stigma against being trans, then that's bad too, you know. So we really have to think about what is really the best outcome for the individual, and basically something that is, you know, pushed by shame, you know, is a tragedy.
Yeah, thank you. I have a question from Susan as well. So the GRA, the Gender Recognition Act in the UK, is currently going through the Scottish Parliament, and one of the proposals is to reduce age of transition from 18 to 16. So given the increase in natal females wishing to transition, do you believe this proposal could result in an increase in detransitioning later?
You know, I do think so. I think that there is not a lot of evidence for transitioning children or even adolescents. The evidence we do have is very specific to early onset gender dysphoria that is so severe that it was obvious to the parents and to everyone else in children without psychological issues. And so that profile is very different than what we're seeing now. So in some regard, we're flying blind in terms of young people who don't fit that very fine, you know, very specific criteria, you know, and clinicians who really aren't even asking questions to delineate whether it was early onset, late onset. You know, even if we are to say that teenagers who are presenting with gender dysphoria, who say that they felt this way all along, but the parents did not see it, you know, at the very least, that's a difference in severity, because the children in the Dutch study, it was severe and lifelong. So to have something in which a young child would be cognitively and behaviorally able to conceal from a parent, you know, we're talking apples and oranges.
Thank you. And from Joanne here, did you seek a breakdown of what the other mental health conditions were that in the survey, and how prevalent was anxiety?
So let's see, for the mental health conditions, I had the mental health conditions that existed prior to the onset of gender dysphoria. And I think I might have had a total number. Let me see if I can flip through this. So the mental health issues prior to the onset of gender dysphoria, depression and anxiety were the most common, where depression was 39% of the natal females and 16% of the natal males. And anxiety was 32% of natal females and 16% of natal males. So, so that is in the paper. I don't know that I have the lifetime numbers of mental health for individuals who were diagnosed later on. So I have that somewhere, but it didn't make it into the paper. But it definitely looked like the natal females had higher rates, but it wasn't statistically significant in my data set. And it might just be that my N was only 100. So,
yeah.
And then I have the numbers for the next study. And there were pretty frequent mental health conditions.
Yeah, and that certainly came up about in your reasons, didn't it? It's the highest reason. Okay, and from Becky, is there any research on the proportions and interrelationships of social transition compared with medical or surgical transition?
I think that's a really good question in terms of what are the the pros and cons of social transition. And I don't think that there are, well, there's a recent study that showed that children who are socially transitioned have high rates of continuation of trans identification in the short couple of years that they looked at. But I do think that we need to really tease out, because there are concerns about whether it increases persistence, whether socially transitioning a child, and I'm going to separate that out from letting a child wear whatever clothes they want, whatever hair they want. This isn't, not about, forcing a child into a role, but the social transition also is about calling the child the opposite sex and calling them by different pronouns and having them use different bathrooms, and whether that becomes self-fulfilling or what the Dutch found early on, they didn't recommend social transition because they found it was much harder for a child to desist, that there was a lot of social difficulty in, that they desisted, but they really had difficulty in telling their friends or to reverse course. So, so I think it's a great question, and there were a lot of unknowns that really deserve more research.
Can I just add to that a little bit? I mean, from my perspective, also there's kind of more to my question in terms of for people making a transition, for whom transition is the right thing, what level do they take their transition, or what path does their transition take? I think that's potentially also an area for future research.
Absolutely. And so at this point, we can't predict who is going to persist and who's going to desist. If we could, this would be a lot easier, because because I think there are going to be different approaches that are going to be most beneficial to one group, and other approaches that are going to be most beneficial to the other group.
Yeah, I mean, like in the UK, obviously the CAS interim report noted that social transition, it's not a neutral thing, and I instinctively I would agree with that. But I do think, yeah, it's an area that definitely a lot more research could be helpful.
Right, and not just the pros and cons overall, but maybe even looking at what ages it would be most helpful, and most where where you can minimize false positives and false negatives. So
thank you.
Thank you.
I think this will be the last question, but we also have one. I would also be interested to know about the prevalence of autism, ASD, and very interesting study. Thank you.
Yeah, thank you. Yeah, in this one, I will take a look. I don't think we had 13% of the natal females had diagnoses of autism spectrum disorders before the onset of their gender dysphoria, and 3% of the males. So that's this study, but there is definitely a known correlation of higher rates of individuals with autism spectrum disorders and gender dysphoria, which again would is an area where more research is needed about what the issues are. And again, some of the individuals in this study obtained an autism diagnosis afterwards. And what I've heard, I think more in the next study, is individuals saying that autism explained their symptoms better than gender dysphoria did. So I do think that there's a real need to be able to determine which is primary, whether one exists without the other, or whether they're coexisting, or what the relationship is.
Absolutely. Well, I think that's a really good place to finish. Thank you so much, Lisa, and thank you to everyone for all your questions. It's been a really interesting discussion. Okay, so we'll finish it there.
Okay,
All right, thanks.